Unmute yourself, Dr. Christian.
Okay.
Okay, so good morning, everyone. I'm Rolandas from Megagen, and thanks for taking this time to join this special Megagen webinar. Today, we are delighted to have Dr. Christian Makary as our guest speaker. Dr. Makary is an oral surgeon based in Lebanon. He is also a former head of oral surgery at St. Joseph's University in Beirut, and he's an active researcher of the effects of immediate loading. As this event is live, we will collect all your questions during the whole session, and and at the end of the presentation, Dr. Makary will answer all of the questions. So please do not hesitate and ask him whatever you like or whatever you want. So Dr. Makary, let me hand over this to you, and the stage is yours.
Thank you, Rolandas. Good morning, everybody. It is a great opportunity to be today talking with special attendees from all over the world. I would like, first of all, to thank Megagen for this opportunity, more specifically the MINEC team. I would like to thank Sean and Lauren, who are attending this webinar with us today. Thank you, Rolandas, for taking the time to set up everything during these past days and for moderating this session. For the attendees, as you said, we can have a Q&A at the end of the session, but if anyone sent any pertinent question during the presentation, I will be able to answer. At certain parts, I will read the questions, and if there is some things that were not well understood, I can answer or take some of the questions during the lecture. So we will try to be as much as interactive as possible. It's not always easy to talk to an audience that is virtually watching us, but that you cannot see. I can just see my balcony from here. So the webinar today will be about loading protocol. And the question that I have to ask at the beginning of this lecture is, how much implant stability can we usually have? How fast loading protocols can be? And is it always possible to have a very high implant stability without causing any disruption or any healing problems? Are we able always to load our implants immediately? When is an indication for an early loading? When is an indication for a delayed loading? And these are the questions that we will try to answer in a scientific and clinical way today, in order to set a rationale on when and how far we can go in achieving high implant stability and faster loading protocols. This is our university in Beirut. This is the St. Joseph University. This is where I work. This is where I teach at the oral surgery department. And I would like to take this opportunity to thank and acknowledge all of the people with whom I've been working in the last 25 years for now. Our faculty members, our postgrad students, because most of the studies that I will be showing during this presentation are studies that were done with their help at the St. Joseph University of Beirut. So today, if you place an implant in your daily practice, you should know that from the moment that you start drilling the bone until the moment that you place this implant and you achieve implant placement into this ridge, whether it is at the mandible or at the maxilla, this is when you can take the proper decisions regarding loading of the implant. Because at that moment, you can appreciate insertion torque, you can appreciate the primary stability of the implant, and this is when you will be able to make the proper decisions regarding loading, and this is also based on the secondary stability that you might expect from these implants. So I would start by defining these works. So what is insertion torque? You should know that an implant is a screw shape, and when you place an implant into the bone, it's a little bit like placing a screw into a piece of wood, for instance. And when you screw something in a piece of wood, you have certain resistance while screwing. This is what we call insertion torque. Insertion torque is the cutting resistance of this screw-shaped implant that is inserted into bone. And the hardest the bone, the higher insertion torque that you might have. And we will discuss later on what are the different parameters that can help us achieve a higher or a lower insertion torque. And we will decide if insertion torque is always good to have, is it dangerous, is it good for bone, is it good for the implant? We'll try to answer all of these questions during this presentation. What is primary stability? A lot of people will be confusing primary stability to insertion torque. These are two different parameters. Primary stability is what we refer to as the micro movement of the implant, which means that when I place my implant into the bone, when this implant will be facing some forces, lateral or occlusal forces, this implant will do micro movements. And these micro movements can affect healing. And the highest these micro movements are, the highest the risk of having a loss of implant during the early period of healing. How can we measure this micro movement? We can measure this micro movement or this primary stability by using some machines. One of the most used machine today in the world is the ISQ machine. This is the Mega ISQ that will give us some numbers, and these values that you can see here, the implant stability quotient, ISQ, will give us an idea on the stability of this implant and will give us guidance whether we can do delayed, early, or immediate loading of these implants. And we will discuss all of these features also during this presentation. And what is secondary stability? In contrast to primary stability, which is a mechanical process, secondary stability is a biological process. And during this process, we will have the bone growing over the implant surface. And this is what we actually call the osseointegration process. So if we look at these implants, if you see this implant to the left, this is an implant that was placed in a bone socket, in a bone preparation, and you see that this implant is holding mechanically because the thin threads are holding inside the bone. And if you look at that same implant a few weeks later after healing, you see that now this implant is holding biologically, because you can see that we have some bone healing around the threads of this implant. And this is the actual osseointegration process. And this is what we can refer to as secondary stability. And you can tell that here where the implant surface, where the bone healing will play a major role in order to give us this perfect secondary stability that we will need. So why and how does these parameters relate to each other? If we look at this, this is what we call the famous Raghavendra curve. It was described by Raghavendra and co-workers in 2005. And this is a very important curve because it gives us a lot of information that can guide us through our clinical decision when we want to achieve a early, delayed, or immediate loading protocol. So if you look at this curve, we have the first curve that relates to primary stability. And you see that at day 0, primary stability is 100%. This is the primary stability that we get. But you know that bone is elastic. And because bone is elastic, this primary stability will keep decreasing over time, over the weeks, because of the elasticity of bone, because the bone will resorb around the implants due to the trauma of drilling or placing implants. But if we leave an implant in an inert space, in a bone that is not living, we will keep losing primary stability until we lose the implant. But what we have in the in vivo or in the human body is that this bone is not inert, this bone is biologically active. This is why from the day when we place our implants inside this bone, we will have bone growing and a biological phenomenon going on. This is why we start having what we call a secondary stability. And within weeks, 5, 6, 7 weeks of implant placement, you see that even though we lost the primary stability, we have a very good secondary stability or osseointegration. And now our implant is not holding mechanically anymore. Our implant is holding because the bone is growing over the implant. And this is why our implant cannot be, is not moving and cannot be retrieved anymore. But you all agree with me that the critical period is this period. It's between 3 and 4 weeks. This is when you start losing primary stability and you start gaining secondary stability. And this is where all the decisions should take place. If you have an implant that will have a fast decreasing primary stability and a low increasing secondary stability, which means that if you have an implant with a bad surface and an implant with a bad geometry, you will have a pitch that is very low. And if you try to do early loading or immediate loading to this implant, you will end up losing the implant and you will have a failure. This is why what you need to have is a curve like this, where primary stability will not decrease in a very fast way, and where secondary stability will take the lead also during the first weeks in order to be able to have a curve where the pitch is not low. And in this type of configuration, you can, of course, be able to do early loading at 4 weeks or immediate loading at implant placement. And this resume everything. This will give you an idea of the whole process. And I will try to go more into details to show you what are the different parameters that can affect primary stability, secondary stability. And here where we will say that bone density, for instance, implant site preparation technique, and implant geometry are very important parameters that can lead to a good insertion torque, a high primary stability, and a very fast secondary stability. And these can, of course, affect your clinical decision. So let's start by talking about bone density. Bone density is a very important parameter. And you all agree with me that if we place an implant into this type of bone, you see that here we have a bone that is very wide. This is a very cortical bone. And this bone is very hard. And if we place an implant into this bone, we will have a very high primary stability of the implant. So a clinical decision in a bone that is hard is different from a clinical decision when the bone is very soft. And we all know that classically we have 4 different types of bone that were described in the literature. And these were described by Lakeholm and Zarb at the beginning of the era of implantology in the 80s. And you see that we have bone going from D1. D1 is a very hard bone to D4, and this is where we have a very soft bone. And you can agree with me that placing an implant in this D4 soft bone will not give us the same primary stability that placing the same implant in D1 cortical and hard bone. So how can we recognize the bone quality before placing our implant? Because obviously this is a factor that can affect our stability, and that can affect and guide our loading protocols. We did a study a few years ago in 2011 that was published, where we did bone core biopsies instead of drilling implant. And the cause was to be able to retrieve the bone, as you can see here, at implant site preparation, and then place our implant in that same site and decide what type of bone we could have in different topographic region of the maxilla, the maxillary, or the mandibular region. And as you can see that histologically we had different type of bone. We have bone that was very soft, as you can see here. This is a D4 bone, and you can tell that in D4 bone we have very little mineralization. This is why this bone is very soft. And you see that on the extreme right you have a D1 bone that is a very cortical bone, and you could tell that there is a lot of mineralization in this bone. And between D1 and D4 you have the D2 and D3 that is a bone that is of medium quality. And this will let us tell that in different parts of the jaws, we have different type of bone mineralization and bone density. As you can see, in the anterior mandible, for instance, we have a mean bone mineralization of 87%, which is huge. And in the posterior maxilla, where the bone is the softer, you can have around 34% of bone mineralization. So this will give us guidance in order to understand that when you're planning implant placement in the posterior maxilla, for instance, you can always expect to have a soft bone, and it is a different decision when to want to do an immediate loading than placing an implant in the anterior mandible. But can we always do bone histologies? Of course, no, because this will be a process that we can only do for research purposes. But usually, how can we recognize bone while placing our implants? One of the easiest technique is what we call clinical perception on drilling. It was described by Mish in 1999. And in this case, Mish described four different type of bone that are based on the way we feel this bone, where D1, that is almost all dense cortical bone, it looks like oak, for instance, because he compared the bone to the wood, and where D4 looks like styrofoam in hardness. So while we are drilling into this bone, we could tell if this bone is hard or this bone is soft. And is it always possible to detect the four types of bone? Based on our studies, we found that it's always easy to detect the hard bone. It's always easy to detect the very soft bone, but there is always a problem to detect D2 and D3 bone that are both usually considered as medium quality bone if we based on this classification that was advanced by my friend from Italy, Alberto Ribaudi, where he described three types of bone: hard bone, medium bone, and soft bone. But is this everything that we need to know about bone? Of course, no. Because sometimes you have a very hard cortical bone that you can see here. This cortical bone can give us a very high stability of the implant, while inside this bone, you can have a very soft bone. So we need to be able also to retrieve all these parameters before taking our final decisions. And you can tell that the cortical, as we see in this study that we did, will affect in a very significant way our primary stability of implants and the insertion torque of these implants. This study is being prepared by my friend and my faculty member, Dr. Lahoud, who is also watching us today, watching this webinar. Vercellotti proposed a different approach to bone classification, where he described cortical thickness, and you could see that we have cases where we have very thick cortical and cases where we have a very thin cortical. And he described the inner part of the bone, which can be a hard bone, like we can see here, a medium bone, or a low bone, as you can tell, based on radiographic images. But today, I think, with the new technologies related to new radiographic technique, to new softwares, like these R2Gate softwares that was developed by Megagen and that you can find on the Megagen website and download for free, and you can use it at ease when you plan your cases. This will give you a lot of valuable information about the bone, the quality of the bone, the type of cortical thickness that you have, and this will guide your decisions, your clinical decisions, when you are trying to place your implants and trying to decide on what's the type of protocol you want to achieve. So this will let us know that any time that we place an implant inside the bone quality, as we described now, the cortical bone thickness, the inside cancellous bone density will guide our implant placement and will significantly affect our implant insertion torque and implant stability. And this is what you can tell in this study that we did in 2011, where you see that depending on bone quality, we have a different insertion torque level, like insertion torque of 125 in D1 bone and 14 Newton in D4 bone. And you see here on this graph on the right that the highest the bone volume, the highest the insertion torque values that we have. So basically, the problem resides in the fact that it's always easy to achieve a high stability in hard bone, but it's always difficult to achieve the same high stability in soft bone. And this is why when we are facing soft bone, it will be difficult for us to be able to predict stability and to predict the early or immediate loading protocol. The second thing that can affect our loading protocol is implant site preparation technique. And you know classically that we have three types of preparation. We have the osteotome technique, the ultrasonic technique, and the drilling technique. Osteotomes were described a few years ago as I think that I have a problem with my screen. One of the questions that was asked is it good to have a very hard bone in terms of secondary stability? It's true that when a bone is very hard, it will be more difficult to have a biological response of the bone. So achieving having a bone that is very hard is not as good as having a bone that is very soft. So there is always the quest between having a bone that is biologically active and being able to achieve our stability. And this is what we will discuss when I will present the new geometry of the N-ridge implant that can give us this an answer to this question. So with osteotome, we can condense the bone, and this will achieve a different bone environment around the implant. But the problem with osteotomes is that we are crashing the bone and we are delaying the healing. The second technique that was described is ultrasonic implant site preparation technique, when you use piezosurgery in order to prepare the bone. And we've done a publication on this technique with our friends from Italy, from Turkey, and the team at the St. Joseph University. And we found that this technique was as accurate as drills. But one of the main advantages of ultrasonic implant site preparation, and this is something that should be also investigated in the future, is that it can affect bone healing, because it can lead to a better bone vascularization. It can have a better bone aspect. If you compare it to drills, drills can crash the bone, and you will understand at the end of this webinar that it is very important to be able to maintain bone around the implant in order to shorten the healing time after we drill and replace our implant. So if we crash the bone, if we destroy the bone, we will have a delayed healing and we will not be able to load earlier. And if you see this graph, you see that by using ultrasonic implant site preparation, these authors, Taki and co-workers, had a better ISQ value. So this is one of the things that can be used if we want to achieve a better bone stability. One of the things also that we can use in order to achieve stability is doing what we call an undersized implant bed, which means that instead of drilling for the final drill of 3.8 millimeter, for instance, as you can see here, we can drill to 3.2 millimeter, and this way we will squeeze the implant inside the bone and we will achieve a higher primary stability. And this is true. You can always do a smaller implant bed preparation. You can always squeeze in your implant inside the bone, achieve a very nice primary stability, but the problem is that what you will be achieving at the same time is crushing the bone, compressing the bone, and this will lead, if you follow these studies, to necrosis around the threads of the bone, and this will delay the healing. This is why I'm saying it's very important to be able to respect bone architecture when you place your implant, and if you want to have a better stability. The third thing that is very important and that can affect our implant primary and secondary stability is implant geometry. And if you look at these implants, this is a picture of implants that were produced by one company, that is Megagen implant, and you see how much implant we have only in this same company. And if you compare this to all the implant system in the world, you could tell that we have thousands of implant design, and each implant design will interact in a different way when it is placed inside the bone. We know for a fact that when we use conical implant, we have a significant higher stability than when we use cylindrical implant, and this is a fact. You cannot use today cylindrical implants and expect to achieve high implant stability. This is why most of implant systems that will give us high stability are conical implant design. It's very important also to have a very good surface microtopography, because at the end, and if you remember the curve that I showed at the beginning of this lecture, the Raghavendra curve, what we need to achieve is a very fast secondary healing. And this is a study that is comparing the X-speed surface that you find on Megagen implant to a resorbable blast media implant, and you see that we have a better bone to implant contact. We are now performing a study at St. Joseph University where we are trying to study the effect of the surface on bone healing around these implants at 4 weeks and at 6 weeks. I'll show you some of the histological slides, but the results are still pending and will be published very soon, hopefully. Thread design. And this is a very interesting study. This study compares two different implant geometry. One implant geometry with a V thread. This is the normal thread that you will find on most implants. And one implant geometry with a knife thread. And this is the type of thread that you will find on any ridge implant. These two implants belong to the same company. They both belong to Megagen. So we're comparing two implants that were produced by the same companies. And you see that when these authors followed up the healing of these two implants, the blue implant, that is the implant, the ridge implant with the knife thread design, had a primary stability that was maintained over time and a secondary stability that was gained in a very quick time. While the implant with the normal threads, with the V threads, had a very high stability at day 0, but you see that this stability was lost over the weeks, and we had at the end a healing path that was different from the knife thread implants. So if you want to do 4-week loading, for instance, to this implant, you see that you are much more in the safe zone when you are using an implant that is not losing stability versus an implant that is losing stability. I'm not saying that this implant, the orange implant, will fail. I'm just saying that the orange implant is not an implant that is adapted for immediate or early loading protocols because it is losing stability in the first weeks of healing. Maybe if we keep measuring the stability, you see that this curve will go up over the weeks, but what is the main thing that we are discussing today is how far can we go? how fast can we load? And how fast can we load means that we need to have a curve that is always very high in order to give us a better stability and maintain primary stability. So each type of implant thread, each type of implant geometry will give us a different insertion torque, a different primary stability, a different interaction of bone with implant surface, because an implant like this one, for instance, will crush the bone. An implant like this one will cut into the bone. Look at these very thin threads. These threads will cut into the bone, will not crash the bone, and this will give us a bony architecture that is still maintained around the implant, which means that we will have a faster healing around these types of implant. And this is proven by studies, and I will show you our study that was performed at St. Joseph University. When we use an implant, this implant with knife threads, like the Eneridge implant, in order to monitor over 4 weeks the healing and see if you can do in all cases and in all regions an early loading. So the idea of Eneridge implant is to drill inside the bone a shape that is exactly the same as the core size of the implant, and let this implant achieve its primary stability only through these very thin knife-like threads. In this way, we will have a minimal pressure on the bone at the core of the implant. This is where the maximum pressure usually gets to the bone. And we will have very thin threads that can achieve a very good stability. So by drilling to 3.3 millimeter, you see that we can use 4 different designs of implants. One that has very small threads, and obviously this is the one that you can use in hard bone, and one that have very deep threads, and this is the type of implant that we can use in soft bone. So this study was about early loading of different thread geometry, a clinical study at 4 weeks. And in this study, we used 40 Eneridge implant with a 3.3 millimeter core diameter that was placed in different types of bone. For all of these implants, we measured insertion torque, and then we measured over the 4 weeks period ISQ values in order to see if we have a loss of stability. And if we didn't have any loss of stability, these implants were functionally loaded at 4 weeks. The protocol, the drilling protocol is always the same. So we always drill to 3.3 millimeter, which is the exact size of the core of the implant. And depending on bone quality that we had, that we could find on radiographic studies and on clinical perception while drilling, we chose upon an implant with a thread that was of 4 millimeter or 5.5 millimeter. And each of these implants will interact in a different way in the bone without compressing this type of bone. So you can see here in this schematic view that when the bone was hard, we used implant like this one, 4 millimeter implant. These threads were thin, but not very deep. So we could achieve a good stability in hard bone. And you see that in cases where the bone was very soft, we used the same core implant, but with a thread that was much deeper. This thread is around 1 millimeter deep, while this one is around 0.3, 0.4 millimeter. And you could tell that if you use this type of implant, the implant with deep thread in the hard bone, of course, we will have an implant that is stuck into the bone, and we will not be able to insert the implant, or we will have a very, very high insertion torque that we will not need. And vice versa, if we use this implant, which have a minimal depth of thread in the soft bone, we will achieve an implant stability that is low and that will not allow us to perform immediate or early loading. So this is the whole idea, and the whole philosophy is to be able to achieve a high primary stability in any type of bone. So if we follow the protocol that we use, as I told you, this implant has a very straightforward protocol. So it's always the same protocol. You go through 3 drilling. The last drill is 3.3 millimeter. regardless of bone quality, you always drill the same, because we need to drill in order to have an implant that is exactly the shape of the core of our implant fixture. And the idea, again, is to be able to achieve a high insertion torque or an optimal insertion torque. One of the questions that I got now is, do we really need to have more than 30 to 50 Newton torque to place the Megagen implant? We will discuss this in details now when I will show you the result of our study. And we will try to see what is the optimal insertion torque that we need in any type of bone if we want to achieve a early or an immediate loading protocol. So you see this implant, the core of the implant is exactly the shape of the last drill that we use, but you see that we have very thin and deep threads that will achieve our primary stability by giving us a very good stability, but without causing any bone compression. And this is very important. We don't need to have a bone compression because we do not need to have bone resorption or bone remodeling. Sorry. So once we placed our implant, this is the second implant that we're placing, and you see that always the geometry of the implant is matching the bone quality. We will then measure our ISQ, which is the primary stability as we described. You see, this is the smart peg that we placed over the implant. This smart peg is always torqued to 15 Newtons, so we don't have any biases, using a MEG torque device. And then by measuring the values of ISQ values over this implant, this will give us numbers that we will discuss. So for the moment, any number does not mean anything if we don't correlate it to clinical behavior of the implant and to clinical decisions that are taken. And if we look at the numbers for these two implants, for instance, you see that for this implant, the implant at the left, we use a 4.5 per 10 millimeter implant with the same drilling of 3.3 millimeter. We had an IT of 69, ISQ of 79, while on the implant on the right, the 26, we used a 5 millimeter deep thread implant, an IT of 48 Newton, and an ISQ of 72. So as a first remark, you see that achieving 48 Newton centimeter in the posterior maxilla is something that you cannot always do predictably with any implant system, because you need an implant system that can adapt to the bone. And this is one of the main advantages of this implant that we are using in this study. So if we look into the IT values, you see that in different bone types, we had, of course, different IT. So it is expected to have high IT in hard bone, type 1, and we have, in this case, 100 Newton centimeters. But you see that with other implant system, in other studies that we did, and I will compare, we had higher values in hard bone. So one of the main of using a 4 millimeter implant adapted to hard bone is to lower our insertion torque in hard bone, because of course we don't need to have a very high insertion torque. And you see that what we need is to achieve a higher insertion torque in soft bone. And you see that here we are at a mean value of 60 Newton centimeter in soft bone, and this is very important if you want to achieve primary stability. So what we observed in our study compared to other study that we did in our group is that hard bone values were lower than with other implant system, and soft bone values were higher than with other implant system. So what is the optimal value of IT that we need to have? We see that in this study, most of our values were around 80 Newton centimeters. And if we try to see what the literature tells us, the literature says that if we have an implant that is lower than 30 to 35 Newton centimeters, this implant is in the danger zone if we want to achieve immediate or early loading. There are a lot of studies. We did a publication recently on this study that you can find. It's on journal materials. It's accessible, so you can download the study. And we see that all of the implants that were in this group were above the danger zone. And this is very important. But if we compare to other studies that we did, like this study that I published using another implant system, you see that we had a lot of implant on this 40 implants group. We have 1, 2, 3, 4, 5, 6 implants that were below 35. So these implants were not candidates for early or immediate loading. We had implants with 15 Newton centimeters. So it's always important, like we have in our group, to have all of these implants above this danger zone. What about ISQ values? ISQ values were, these are the values on type 1, type 2, type 3, type 4, and all bone. And what does these values mean, actually? For you, it's only numbers, but if you compare it to scientific evidence, you see that there is a threshold that was described in the literature also. And this says that any implant that is lower than 60 in ISQ is considered an implant in the low stability zone. And this is an implant that is not candidate for early or immediate loading protocol. This is an implant that is at risk, and we should wait for 3, 4, 6 months before loading it. Any implant that is below 70 is considered an implant with medium stability, where in certain conditions we can do early or immediate loading. And any implant that is above 70 ISQ is an implant in the high stability zone. And these implants can be always loaded immediately or early loading. So all of our implants were in the high stability zone, and all of our implants were candidates for early and immediate loading. And you can see that in other studies also, we had a lot of implants that were in the low to medium stability zone. And we had a loss in implant stability that was not described in our series. In our series, all of the implants were stable over time, and we did not have a pitch, if you remember the Regavendra curve. We only had implants that were stable over time, and this is very important if you want to do immediate loading. Because if we go back to this curve, we can have a very high stability at day 0, but we need it to be maintained. And this is something that was described with this Megagen implant. You see that all of our implants were in the high stability zone and in the maintained stability zone above 70, 75. So we had all the implants were candidates for immediate loading and early loading. The surface is very important, as I told you. These are some of the histological images that were sent by Dr. Tonino Traini in Italy, who is working on this study that I said. And you see the bone that is healing around the X-speed study. And these are wonderful results. It's only anecdotal result for the moment. I'm just showing it for you, but we will have the full results soon. But you can see that there is a lot of bone growing at 4 weeks and at 6 weeks over these implant surface. And this is very important to have an implant that will achieve a very high and quick secondary stability, so we can be sure that we can load this implant early or immediately. What about implant loss around this implant? You see that we have a minimal marginal bone loss, 0.18 millimeter at 12 months. Look how the bone is maintaining over these implants. This is the situation before. This is the situation at 1 year post-operatively. And you can tell that this implant is very well maintained at the neck of this implant. And this is something that is very good at 1 year. That means that high insertion load did not affect marginal bone loss, did not affect bone healing. And you could see how we adapted the geometry, the threads of this implant to the bone that we had. The bone was hard in this case, so we used an implant with minimal threads. The bone was soft in this case, so we used an implant with deeper threads. Another case, and you see how this bone was maintained in soft bone. This is a single implant that was loaded also at 4 weeks at the molar site in the maxilla, because we could achieve a very high stability using the proper geometry, and because the implant surface could achieve a very quick secondary stability, and we had a maintained stability over time, we could load this implant at 4 weeks. Another case, also, you see the result at 1 year. You see how stable is the bone around these implants, and look at the implant geometry that let us achieve a very good primary stability and also a maintained stability over time. So if we come back to these cases, you see that we didn't have any loss of stability and any loss of bone around this implant, even though in some cases we had a insertion torque that was high enough. So what is the threshold for an insertion torque? How far can we go? If we say that everything that is below 100 Newton can be accepted as being in the comfort zone based on some of the studies that are in the literature and that are mostly discussed in the article that you see below, what about the cases that we had and that were above 100 Newton? Is it safe? Does this high insertion torque affect the bone? Will it lead to a necrosis of the bone and the loss of the bone? This is the question that we should ask. And in order to answer the question, I'll show you some cases. These are two implants that I placed myself. These implants are from a very famous and very good company. I'm not criticizing the company. I'm just saying that when I placed this implant in hard bone, I had a very high insertion torque. And maybe I had a very high insertion torque because I did not respect 200% the drilling protocol. But these kind of implants are not made to withstand high insertion torque. These implants are made to have a very low insertion torque, below 30 Newton centimeter, because the philosophy around these implants is to be able to place the implant with minimal pressure over the bone and let the bone heal gently around these implants. So if you place this implant with a high insertion torque, look what happens at 6 weeks. You lose the implant, you lose the bone. It's a catastrophe for you and for the patient. But these implants, if you cannot achieve high primary stability with this type of implant, you cannot predict doing, or you cannot take the decision to do a early or an immediate loading on these implants, because one of the main features to have a early or immediate loading is to be able to have a very good stability of the implant, primary and secondary. These are other implants, and you see how we lose the bone at 6 weeks, because this implant geometry is not adapted to withstand high insertion torque. These are other cases where you lose the bone also at 6 weeks, at 8 weeks, because again, these implants are not made to withstand high insertion torque. This is an implant, an annually ridge implant that was placed in a very, very, very hard bone. And when I placed this implant, I followed the protocol. It was part of the study. And look what I got. I had a 186 Newton centimeter, which is huge. This is the highest insertion torque that you can have, because at that point, you can destroy the implant, you can destroy the implant connection. And of course, it's not, our aim is not to get this type of insertion torque. We had a huge ISQ values, 83, which means that you have the maximum parameters for these implants. So when I place this implant, and as a clinician, you should tell that when you place an implant like this, most of the times, you will not be able to stop the process once the implant is stuck. So we have only one decision, is to keep going and placing your implant. So what I expected in this case is to lose the bone around this implant. And this is something that usually everybody will have if you have an implant with such insertion torque. But if you look at this implant at 4 months, you can see that I had 0 bone loss. This implant could withstand this very, very high insertion torque because the geometry of this implant was adapted to the implant site preparation, and because the threads of this implant did not compress the bone. And if you look at the result, you see at 18 months how this implant that you can see here in the middle was maintained, how bone healing was maintained, and how we did not lose any of the bone. So if we come back to this and we say that there is a danger zone if you want to do an immediate loading, and there is a comfort zone, we could tell that when we use Megagen implants or implants that have a geometry that is adapted to bone and that can withstand high insertion torque, with these implants, even though we went all the way up above 150 Newton, we did not lose the bone. Of course, my message is not to tell you to place implants with such high insertion torque, because you can have a damage on the connection. This is why in cases where you have a very high insertion torque, you should adapt the implant site preparation and prepare with a drill that is present in your kit, that you have in the kit, in order to reduce the insertion torque. But I'm saying that when you use the proper implant that is adapted to the bone and that can withstand insertion torque, you will not lose the bone around these implants. And this is why with implants like this, you can always predict to have and to achieve a high primary stability and a maintained secondary stability. So in conclusion, what should you expect from an implant? I would say that I would expect to have an implant that have an easy implant site preparation technique. And as you've seen with this Eneridge implant, it was a very easy preparation technique because we always prepare to the 3.3 millimeter and we place the implant, regardless of bone quality or bone density. We need an implant that can achieve high IT, but no osteocompression. And you could see that because of the geometry of the implant, because the implant site preparation was adapted to the core diameter of the implant, because we had a very thin knife-like threads that could achieve this high IT but did not compress the bone. We could place these implants with very high values, and you see that radiographically and with a follow-up, a published follow-up of 12 months around these implants, we did not lose any bone around this implant. Then we need an implant that will give us a high primary stability, which means a high ISQ value at day 0 and a maintained stability over time. And you could see that with these implants, with the series that I showed you, all of the implants were above the threshold of 70 Newton ISQ, which is a threshold above which you can do immediate or early loading of the implants. And what is most important is that we had a maintained primary stability, which means that at 1, 2, 3, and 4 weeks when we did our measurements, we did not lose significantly stability over these implants because bone was not disturbed, bone was not compressed, and we had a proper healing around this implant. And we need an implant that will give us also a dynamic, quick healing over time, because it's very important, even if we have a maintained stability, you know that over weeks, and if you go back to the curve that I showed you in the presentation, you will lose the stability. So what we need is to be able to have an implant that will give us a very quick secondary stability and an implant surface that will bring in bone in a very fast way in order to grow over the implant and achieve a secondary stability that can protect our implant over time. So once we go above 4 weeks, we know that now the bone is taking over, the biology is taking over, and this implant will allow us to do a predictable, early, or immediate loading, regardless of bone density. So the idea at the end is to say that if you need to do predictably early loading, if you need to do predictably immediate loading, you need to have an implant that have these features. And this implant that you see on the right, this Eneridge implant, could answer these questions. So this is an implant that can be adapted to this type of loading protocol. So in answer to this question, how higher stability and faster protocols, how far can we go? I think that we can go very far if we have the proper tools and if we use the proper implant. So I think we're done with the presentation. I had some clinical cases to show, but obviously we don't have time anymore because we've gone beyond the 45 minutes. We're at 55 minutes. So I'm open to any questions. Rolandas, it's up to you to moderate now.
All right, thank you, Dr. Makary, for your excellent presentation. That was really bravo.
Thank you.
We received a couple of questions from our online audience, but as I understood, you just answered all of these. So in closing, I just want to thank you, Dr. Makary, once more, and thank you for the audience for your time and active participation. The next Megagen webinar will be held on Wednesday, on April 22nd, on the same time, when our guest speaker will be Dr. Roberto Rossi with his topic of clinical evaluation of implants inserted in ridge post-guided bone regeneration. And if you would like to know more about our special webinar program, so check out our recorded lectures. So please go to www.imegagen.com. So stay safe, stay healthy, and see you next time. Goodbye, everyone.
Thank you. Thank you. Bye-bye, everyone.
Bye-bye.